Mm-mm.
Welcome, everyone, to session 2 of Addressing Pediatric Feeding Disorders in Schools. Tonight's session is Legal and Ethical Considerations. We want to remind you that we are recording these sessions, so we ask that you save your questions until the end. You can also plug them into the chat so that we have them for later. Remember to protect any personal or identifying information if you're asking about particular students on your caseloads. And then we do ask that you share examples of some complex cases that you've had in your district. We've gotten a couple already, and we will be using those later in the series during session 8 for some group work. And then, so tonight's session, like I said, is legal and ethical considerations. And at this time, I'll introduce Jen Eggert.
Thank you, Dawn. Welcome, everybody. I'm hoping that for many of you, I'm saying welcome back. And I'm hoping that equally as many of you are welcome to newbies. So we're excited to have you if you've decided to join us. Hopefully you heard great things about our first session and are excited to dive into this topic of addressing pediatric feeding disorders in the schools. As Dawn said, my name is Jen Eggert. I am a clinical assistant professor and speech language pathologist at Marquette University. And I have the honor of leading us through this journey that's going to take us through the whole school year. So lots of topics ahead. Dawn, let's go to the next slide. What I wanted to do here was just do a little review of what we did last month. So last month we started by just going through an overview of what is pediatric feeding disorder, right? And as you can see there on the slide, we talked about the 4 domains being medical, nutrition, feeding skill, which encompasses both our sensory system and our motor system and how those two work together. And then the psychosocial domain. We differentiated feeding versus swallowing, feeding being that opportunity that we use our skills of our hands and our mouth to get the food in, and talking about swallowing being mostly not within our control once we start to swallow, and this being this automatic piece where the food goes through the digestive system. We defined the 4 phases of the swallow, and we talked about pediatric feeding disorder within the schools and then also within the ICF, or the International Classification of Disability, Functioning, and Health Model. And again, if you weren't able to join us for that series, for that first one, rather, I should say, more than welcome to go and find that recording. We'd love for you to see that information too. So let's go to the next slide. So we want to move on here now to a topic that we heard a lot of request for in the chat. And luckily we had it planned for our second topic because we knew it would be really important. Some of the questions that we had and that you had were, what legal precedents has been set and what are the implications of current case law? How do we apply special education policy to students with pediatric feeding disorder, or PFD? What are the ethical considerations for working with this population? Are there safety considerations? And what about our scope of practice? And this isn't, again, just for speech pathologists or occupational therapists. We know and we hope that many of you are paraprofessionals, special or regular educators, physical therapists, nutritionists or dietitians. We hope that we also have some individuals who may be working in administration with us. So the scope of practice comes up a lot across the districts within all of your personnel. And we're going to talk about that specifically today. And then the last question we had is there guidance here at the state level? So I'm going to start a little bit by answering that last question first, and Dawn will jump in if she wants to. But the guidance at the state level starts here. We decided to put this series on first, share this information, continue to gather information and vet what we felt was important to you, the individuals who are working in this every day. And then we will go back as a team, myself and all of the amazing members of this team that Dawn has collaborating on this, and we are going to put together some guidance information for the state. So that guidance is coming, and this is part of it. Let's go to the next slide. So I did a lot of reading about this, and it's quite complex. So I understand your hesitancy and your questions on this and really want to acknowledge that. In my reading, it was easiest for me to really break this up into a balancing act of looking at what I really focused on last time, which was student participation, something that we're all focused on, which is student safety. And then the questions that came and the questions that we had too, which were, what are the legal and ethical implications and considerations? And I drew arrows there going between all of them because it really is a balancing act of how do all of these pieces here interplay with each other? Because we want student participation, but there's also safety considerations with that, legal implications with that, and ethical considerations. And so they all interplay together. Let's go to the next slide. So student participation really starts with the federal law, and I know that you're all familiar with this, but I think it's always good to review. So IDEA, or the Individuals with Disabilities Education Act, ensures that children with disabilities have a free and appropriate public education, otherwise known as FAPE, which all children are entitled to. And again, I really capitalized that word all children because as we talked about last session, we know that there are more and more children being born with significant medical complications. We know that there are more and more children surviving with significant medical complications. We know that the diagnostic rate of autism continues to rise. And this is another large piece of our population. And so all of these children are coming into our school systems and we are having the pleasure of interacting with them, but also the responsibility of making sure that they participate. IDEA also ensures that students with disabilities have special education services, including related services. And a reminder that health services are a related service. Let's go to the next slide and dive into this a little bit more. So Dawn put together this lovely slide that talks to us about the special education disability categories. And Dawn has those linked there. Those will link you to the different pages. So our special education disability categories are, again, autism, significant developmental delay, or SDD, deaf and blind, intellectual disabilities, specific learning disabilities, or SLD, orthopedic impairment, which I think we might forget about a lot because we don't necessarily see that, but I know our OTs and PTs certainly look at that as a possibility. Emotional behavior disabilities, speech or language impairment, blind or visually impaired, deaf and hard of hearing, traumatic brain injury, or TBI, you may hear that referred to, and then other health impaired. So feeding and swallowing concerns do not require a separate IDEA classification. They fall there right underneath other health impaired, which again is one of our 9 special education disability categories. So it's very reassuring to all of us, I think, to know that we have somewhere to put these children in terms of the paperwork, right? We legally protect ourselves and our children through the IEP process, and this is the start of it. Next slide.
I'll just add to that, Jen, that really feeding and swallowing concerns could end up being disability-related needs under any of these categories. So that's one thing that we really wanted to mention, is that there's not a separate classification for feeding and swallowing.
Thank you for clarifying that, Dawn. Yes. So again, as Dawn just helped us to clarify, this is not an eligibility issue, right? If a child is eligible for an IEP, then they may receive pediatric feeding disorder services underneath related health services. So health services are for students who need the services of a nurse or other qualified professional to be able to attend school and benefit from the curriculum. Related services for these individuals may also include occupational therapy, physical therapy, and speech language pathology. And again, as Dawn was stating, we may have individuals who fall under the autism diagnostic disability category, or intellectual disability, or speech and language impairment. But if they need that other health impairment, that is a way for them also to receive that. If a student is not eligible for an IEP, then the student may receive PFD services through a 504 plan. And those 504 plans provide accommodations without the need for the specialized instruction. And I think that these 504 plans are probably less used for our children with PFD, because I think a significant number, and Dawn or Michelle or anybody who's on here can certainly correct me, but I think a significant number of our children with PFD really do fall underneath one of those special educational disability categories. But we do have kids that once in a while, they do just fall underneath that 504 category. I'm just thinking of myself. I'm working with a child right now who is completely typically developing in every way, except for a diagnosis that impacts their digestive system. And so for him, we have a 504 plan in place at the school. Next slide. So student safety is another thing that we said was really a concern, right? So we talk about local parentis, which is in place of the parent. And school districts have an obligation to act as the parent or caregiver regarding keeping the student safe while at school. And we know that there's a number of things that we do to keep children safe at school. We practice fire drills, we practice tornado safety, and we make sure that children line up. We make sure that everybody's accounted for on field trips. Feeding is also a student safety issue. And so it is the least dangerous assumption that the district must do what is assumed to be least dangerous, right? And this includes meals and snacks. So again, if we're taking children on a field trip, we are going to make sure that we are using a bus that the school district has provided, right? We are going to make sure that we are going somewhere where we have permission slips signed. And this is the same thing that comes into place with feeding and swallowing, is that we have to make sure that we have all of these pieces in place. And we're going to talk more about this when we get into our discussion of collaboration. So this is going to include things such as swallow studies and medical recommendations. So making sure that we are doing what is the least dangerous for our students is what will ensure our student safety. Next slide. So there have been a lot of legal implications in court cases related to this. And it was very interesting to go through all of this information. Some of it is, I would say, a little bit older, as we're going to talk about here, the 1984 Supreme Court case. And some of it's relatively new. We have a case here as soon as 2013. So in 1984, we have the link here to the Supreme Court case, Irving Independent School District versus Tatro, which was a landmark ruling that granted disabled students the right to certain health services in schools. And for this child in particular, catheterization was found to be a related service versus medical, as it did not need to be completed by a licensed physician. So this was a child who required catheterization, and the school district was saying, no, this has to be done by medical personnel. But it was not something that needed to be completed by a licensed physician. It was something that this person's caregivers could be trained to do. And we think about all of the things that we as professionals are trained to do, especially those of you who work in special ed or who are paraprofessionals. You are trained to do a lot of things with our kids. Think about kids who you are doing toileting with. Think about some of our kids who may have orthopedic or other mobility impairments and how you are doing specific transfers with them or having them in specific wheelchairs or whatnot to help them. So again, if we can be trained, if it doesn't need to be completed by a licensed physician, then that is something that we can provide in the school. And it is a related service, not a medical service. So another example of that would be providing G-tube feedings or GJ tube feedings, right? A lot of you paraprofessionals out there, I bet could start a G-tube better than maybe some of the GI doctors who don't really do it that often. You are the frontline personnel. There's some other cases here, and we didn't put links to them all in because we had a hard time finding some of them. As far as the links, that would be something that was useful and digestible, but we still wanted to include the information. So the New Mexico case from 2003 stated that the district must provide a modified diet. And we do have one of our dietitians on this team. They aren't able to join us today, but that is certainly a member of this team that Dawn has put together. And in specific, this child needed access to food that was mechanical soft diet, so very easy to chew. And they needed to have some specific positioning during and after eating. They needed thickening of their liquids, and then some careful monitoring to make sure that they weren't refluxing and then further causing lung damage by aspirating it. And so again, this was something that we then learned through court cases that the school district could provide and ensure that student safety while also ensuring that students' participation. In the 2004 New Hampshire case, the district's failure to attend to safety in feeding resulted in hospitalization for aspiration pneumonia. And so again, this was a significant case in that they were not addressing the diet and feeding recommendations found in the medical records. And so because of that, the student had a significant medical emergency. In Arkansas in 2012, we had another case here where there was an established need for health and emergency plan. And we have emergency plans for all sorts of things, right? If you have kids with seizure disorders, think about that. There's rescue medications that we give. If we have children who have allergies, food allergies, allergies to bee stings, EpiPens are not something that we shy away from. We're very familiar with them. We carry them on us sometimes so that we can keep that child participating and safe. And then the Louisiana 2013 case told us a little bit more information about supervision while students are eating. And there was a child who was not supervised appropriately while eating, and it resulted in a severe choking episode and eventual death of this child. So again, very, very important information for us to think about, in that there have been instances in other districts where issues have occurred and resulted in court cases that have now led us to know what is best practice for these individuals, what is going to allow us to keep these children safe, and what can we legally do? Because again, we are not medical professionals, we're practicing within a school district, but we are doing things that are not needed to be done by medical personnel. All right, next slide. So continuing on when thinking about legal implications, the USDA, or the United States Department of Agriculture, and I just realized that that says UDSA, and we'll have to fix that in the slides. A typo. The USDA regulatory requirements state that school lunch programs must modify foods when needed. So modification of foods can seem like things of avoiding allergens, right? Again, something that we're very used to. But modifications of foods may also mean, as we've heard in some of these court cases, things such as modifying the consistency of the texture, making sure that it's soft enough for a child to eat. Thinking about some of our children on the autism spectrum and where they may have certain foods that really, really provide them with great nutrition, but may send them into a spiral in terms of their sensory systems and ability to even be near those foods. So we need to think about modifying foods for individuals. So for school districts that participate in the USDA programs, which is the majority of districts, unless you're looking at a private school, although even some of those still participate in this, these regulations require substitutions or modifications in meals for children who are considered disabled or whose disabilities restrict their diet. This is including children with feeding and swallowing disorders who are IDEA or 504 eligibility. So again, we're seeing this nice consistency here across what are our, where are we staying in our lane? Okay, next slide. So in terms of the USDA, again, they have some specific guidelines, specific information for an individual who is the school food authority. And school food authorities must obtain a written medical statement from a state licensed healthcare professional in order to receive reimbursement for meal modifications when the modified meal does not meet the program meal pattern requirements. So as you know, one of the things that we are doing when we're providing children with nourishment is not only providing them with nourishment, but providing them with healthy nourishment. And when we think through our administrations that we've had up from the presidential standpoint, you can remember Michelle Obama and her gardens and talking about fruits and vegetables. And she was really talking to all of these things that we do through the USDA and the food programs. And so it's really a carryover of, again, what are our major food groups and what are we offering to children in terms of not only servings, but portion size. And again, if we have children who cannot consume those from a safety standpoint, from a sensory standpoint, from an allergen standpoint, we do have the right to make a modification, but who's ever in charge of that, our school food authority within the district, must get that written medical statement. And that's where, again, our collaboration with our healthcare professionals comes in. So these medical statements are going to provide some very specific information about the child's physical or mental impairment that is sufficient to allow the school food authority to understand how it restricts the child's diet, an explanation of what must be done to accommodate the child, and the food or foods to be omitted and recommended alternatives if they are appropriate. Now, we all know that there are children, especially our children who are autistic, who may only eat 5 foods. And so there may not be alternatives. Now, you're all thinking, oh my goodness, okay, so I have to find out who my school food authority is, and I'm going to have to get them to collaborate with this licensed healthcare professional, and we're going to have to get this information, and this is really great, Jen, you're giving me all this information, but you just added to my workload. Well, the good news is we didn't. So legally, you see there in the gray box that the IEP or 504 can serve as the medical statement if they state the same information. So that is a huge time saver for us. Again, we will be talking about collaborating with medical professionals. We want to collaborate with medical professionals. But if a child comes to school with an EpiPen and the parent says they are allergic to peanuts, we can have that in the IEP. We can include all that information in the 504 if it's just a 504, and then legally we are covered. Okay, next slide. Just keeping an eye on the chat here, and I don't see anything in there. So as a reminder, you're welcome to drop things in the chat if you would like. But the lack of information tells me, or the lack of questions really is telling me that you guys are very interested in what we have to share today, and this is a really important topic, and you're just taking this all in. So I really love that. But I don't want to have you not asking questions if you have them. So let's go into one of our other main areas, which is our ethical considerations. And I'm really lucky here to have some of my team members with me who are going to pop on here after this slide. But when we look at our ethical considerations, we are reminded that we have team members, and we are a team, who are working with the student with PFD. And this team may include, but is not limited to, the speech therapist, the occupational therapist, the physical therapist, special and regular ed, all of our paraprofessionals, administrators, nurses, nutrition team members, etc. So a lot of individuals there. Now, every team member has their own profession, and therefore they have their own code of ethics. And that code of ethics, again, is a set of principles and standards that guide professionals in their conduct and decision making. And so these set of rules and principles are really designed to encourage ethical conduct among a group of professionals. So it is very ethical of you all to be thinking about these questions, to be asking these questions, because again, you want to make sure that you are working within your scope of practice and that you're working within your licensure. All right, next slide. So you often hear doctors when they take their oath, right? The Hippocratic Oath. It is first do no harm. And that applies to all of us. First do no harm. And so we have a variety of different codes of ethics there. And so right now I'm going to pull in some of my team members here. I'm going to start by introducing you to Luis, who is going to cover us from the nursing standpoint. Luis, do you want to talk a little bit about the code of ethics and thinking about that from practicing within your limits and also collaborating within the interprofessional team?
Sure. So what I would say, first of all, is, school nurses have a code of ethics from the American Nurses Association, but Really, I think what we're talking about here is the scope of practice for nursing, that the nurses, because the code of ethics are going to, say that you maintain confidentiality, that you treat everybody as individuals, that that you don't discriminate, and those type of things. And that's kind of, kind of a no brainer and kind of a basic thing. But it's really the uh, professional scope of practice that I think school nurses might get a little hung up on or think about it. So, and when I hear questions about pediatric feeding disorders or how school nurses are involved in feedings, most of it all is that who should be doing that and what is the scope of practice? Is that something that nurses do, or is that something, particularly when you're talking about training, is that something that someone else, their scope of practice, and they're better equipped because of their scope of practice to do the training for someone who might need some special feeding techniques and things like that. So that's really what we're looking at. In nursing, our nursing profession would say that what we do as a professional nurse, which is as a registered nurse, is the execution of procedures and techniques in the treatment of the sick. And so that means that you have someone who is sick, has an illness. I don't know that from when we've been sharing here that you would really consider somebody with a pediatric feeding disorder as an illness of itself. You definitely would need to have medical orders for doing things beyond the scope of what a nurse is. But the practice of nursing also includes the execution of general nursing procedures and techniques. So things, nurses don't need a medical order to do an assessment on a student, or to take a blood pressure, or to look at a wound and things like that. The student comes in, but you would need to have a medical order when it's a medical procedure and you're considering that they're doing that. So again, I think that's where it falls with school nurses, is that you need to be thinking about what is your scope of practice. Do you need to have a medical order? And then really, again, our scope of practice says that you need to be competent in what you're doing. So either you as yourself, if you yourself are doing the procedure, helping with something, or in the case that you might be delegating. So Jennifer had mentioned tube feedings. And again, that would be something that would probably be more under nursing scope of practice than it might be the speech therapist scope of practice. But in order to delegate that to someone else, the school nurse would need to have medical orders, because that's not a nursing procedure, that's a medical procedure. Two, the nurse would have to be competent. So if you as a school nurse aren't competent in doing tube feedings, you need to become competent to do it yourself. And you also need to become competent if you're going to delegate it to someone else. So those, I think, are some of the key issues when you're thinking about again, calling it ethical decisions, but it's really the scope of practice for school nurses is making sure that you're competent, that you have medical orders, and that you are the best person to provide that training. If there's someone else, some other professional that it's better fits under their scope of practice, they certainly can and probably should be doing the training. So, thanks, Jennifer.
Thank you for those highlights, Louise. And I think, again, how you summarized that was so important, of thinking of, is this within my scope of practice? Am I the best person to be doing this? Am I competent in doing this? And do I need a medical order for this? And I think you touched upon a really important point there that I just want to re-highlight, which is, you said if a wound came in, you could assess that, right? You could look at that, but you're not going to start giving a child stitches in the office, right? And so that assessment piece, I think, is so important for us to think about, that we are constantly looking at, again, assessing how do we keep our students safe, and then what is our action step based upon what we can do within our scope of practice, legally, etc. So I think that those were some really good points, and I just wanted to reiterate that idea of what is our action step based upon our assessment. So I'm going to ask now for Michelle, who's going to cover our occupational and physical therapist scopes of practice.
Hi. Yeah, so I am the OT and PT consultant in DPI, and we do have AOTA core values, which talk about freedom, indicating and valuing each person's right to execute their autonomy and demonstrate independence and initiative and self-direction. And their occupations may play a major role in their development of self-direction, initiative, and ability to adapt and relate to the world. So that is a piece of what we do, is facilitating freedom in occupations. And I guess I'll just start with OT. So feeding and eating is an everyday occupation that kids take a lot, that most kids take a lot of pleasure in. And when there's struggles with feeding and eating, we can be part of that intervention. And in our scope of practice, we do work with students who may struggle with self-feeding and participating in the feeding program in whatever way they can. And we often will work with our speech and language pathologists and the nursing team in a school setting to really work as a team. That's the key there. And who was just talking? Louise, I think. Was talking about the idea of identifying who has the best skill set to provide the intervention and who has the background and knowledge base. So sometimes there are OTs who do have a lot of background and knowledge in feeding and eating, and it might be appropriate. However, that does not happen without first a conversation and a sort of a IEP team decision about where that's going and who's really taking the lead on those kinds of things, feeding and eating, at whatever level that they are. And then obtaining the appropriate permission from the medical professionals involved. Physical therapy, if we're looking at their code of ethics, we're thinking about being trustworthy and compassionate and addressing the needs and rights of the client, including altruism, collaboration, compassion, and also adhering to their core values of their profession and the best interests of the patients and clients. Oftentimes, physical therapists are not going to have the level of background in feeding and eating, and even specifically self-feeding and working on the daily living skill of feeding themselves and accessing the food and feeding environment. However, our physical therapists are going to be very involved in positioning. And positioning comes into play quite a bit when we're thinking about all kinds of feeding and eating issues. So we do want to incorporate that physical therapist. That physical therapist will need permission from a physician to provide therapy in a school setting, and medical information from a physician to do so. That's in their practice for IEPs and providing school-based practice. So they're going to really be involved in what's the best place for this child, the student, to be positioned in terms of being able to access their feeding program. And those are really the big picture ideas related to OT and PT and feeding.
Thank you, Michelle, for helping us again to differentiate occupational therapists being those fine motor self-help specialists who are really helping our kids to get the food in their mouth through the fork, through the spoon, using a knife with their fingers, and then also helping from a sensory standpoint, the occupational therapist certainly will. And then thinking about our physical therapists and how important they are for positioning. And many of our children, especially who have any sort of neuromuscular difference. So think about kids with high tone, such as cerebral palsy. Think about kids with low tone, such as Down syndrome. They are all going to require that assistance to make sure that their body is supporting them safely so that they can eat. And for some of you, this may be new, and I really respect that. So I be careful, but certainly, try to like drink something if you're all uptight, or try to like drink something if you're down low. We've all done that, right? Where we're laying in bed and I'm like, I can take a drink of water, and then you're like, no, wait, I cannot take a drink of water, and it ends up disastrous. There's water going down your face, your water's all over your comforter, now you're coughing and gagging. And so think about kids trying to do this every day, all the time. And so that positioning piece for so many of the children that we work with is just such a huge piece to safety. And that doesn't even just mean making sure their body is upright in the correct position, but it also may mean that these physical therapists are bringing in all that special equipment that they use, looking at wheelchairs, looking at seating, putting an extra towel roll next to somebody, and making sure that not only are we doing that, but doing that consistently, again, so that we are being the best safety advocates for our kids. Thank you, Michelle. So finally, I want to turn this over to Anne, who's going to cover speech therapy. So Anne, we'll turn it over to you here.
Okay, thank you. So I'm Ann Berry. I'm the coordinator for speech OT-PT for Racine Unified School District. And I just wanted to, we also have a code of ethics, and a few of the principles that we have include that individuals shall provide all clinical services and scientific activities competently, just like the others. Individuals who hold the certificate of clinical competence shall engage in only those aspects of the profession that are within their scope of practice and competence, in considering their certification status, education, training, and experience. And it also includes that individuals shall enhance and refine professional competence and expertise through really lifelong learning, and that's applicable to their professional activities and skills. And individuals in administrative or supervisory roles shall not require or permit their professional staff to provide services or conduct activities that exceed the staff member's certification or competence or education or training. And then the last one is that individuals, like everybody else has said, should work collaboratively with members of their own profession and or members of other professions when appropriate to deliver the highest quality of care. So I just want to point out that the part about being competent and not feeling competent in this area, if that's the case, you should ask your district for support to participate in training or receive mentorship that could include training and support that would be needed. And if that's the case, then it should be listed in the program modifications part of the IEP and the supports for school personnel section of the IEP.
Thank you, Anne. I just wanted to clarify and build upon something that Anne said. So the state of Wisconsin, as we know in the United States, each state has its own unique interpretation of the law and licensing. And in the state of Wisconsin, as you know, we have this dual licensure. And so Anne had mentioned that speech therapists with their certificate of clinical competence must follow the ASHA Code of Ethics. But I want to clarify that we have a large number of very competent speech language pathologists whom do not continue to carry their certificate of clinical competence. And so for those of you who are maybe a speech therapist who doesn't have your CCC, or if you're working with a speech therapist who doesn't have their CCC, I don't want you to get nervous and say, well, but do I have an ethical person with me? Absolutely. Anybody who is a speech language pathologist, regardless of whether or not they still have or never got their certificate of clinical competence, is required to follow the ASHA Code of Ethics. So all ASHA members, whether or not they have that, are subject to the ASHA Board of Ethics. And that means also that, you know, they're working under a state license, which also has its own ethicals. DPI has its own ethical, right? So we're looking at this and saying, you know, for those of us who may have differences in licensure from a speech pathology standpoint, we are all still following the same code of ethics.
Thank you for clarifying that, Jennifer.
Yeah, of course. Okay. All right. So let's go ahead and go to our next slide then. And again, I think we think about the buts, right? So students have a right and need to participate in meal times, but some of the things that some of you have alluded to, either from our last session or even Anne alluded to a little bit, saying, I don't have training in this area. I don't want to put myself or the student at risk. We are short on staff. We don't have anyone who is interested in leading this effort. And these are all legitimate questions. I hear your questions. Your school districts hear your questions. But if we go to the next slide, I want to think of it as an and. So students have a right and need to participate in meal times. And I, as a professional, am responsible for implementation. And we really visited that point pretty significantly during our first session, where we talked about, we are not here to make you oral motor feeding, speech language pathologists, OTs, paraprofessionals. That's not our goal. Our goal is to have you doing the carryover and the implementation. We have medical professionals and caregivers whom are part of our teams. And boy, those caregivers certainly are experts in their kids, right? Students have the right and a need to participate in meal times, and I can minimize risks by alerting administration of limitations and competencies. I can also review safety policies and procedures. I think that that always goes to us speaking through, get it in writing, review what the rules of your districts are. We can look at staffing options and creative solutions while optimizing safety. And we ethically cannot ignore an area of need due to our disinterest. So I'm going to be really transparent with you. I am almost 50 years old. And when I went to school, we learned about augmentative and alternative communication through something that was back then the thing that everybody did. And it was called, it wasn't rapid prompting. Anyways, we don't do it anymore. And it was a very inappropriate way to help individuals do augmentative communication. I never learned about how to use a computer to have an individual talk. I never learned about any of those. But I had to keep up with it, even though it wasn't my area of interest, even though I didn't learn about it. And so that's been a real challenge for me in my career. My area is feeding and swallowing. I'm not really into computers and tablets and all of those things, but it's something that I've still had to do, even if it isn't my big area of interest. So thinking about, again, just because it's an area of disinterest or not an area of specialty for us, it's something that we can't ignore if it's within our scope of practice. Okay, so we are doing good on time here. We have about 15 minutes left. And I wanted to do a little bit of a brain dump activity, because I like to think about getting outside of our comfort zone and personal growth. And the quote there, you are not growing as an individual if you are comfortable. And I think it's really good to feel uncomfortable. So thinking again about these 4 areas that I broke this down into to make it a little bit more digestible: student participation, student safety, legal implications, ethical considerations. For those of you who are in our meeting here today and have access to the chat, I know I see some of you being like super school professionals like you are. Like, I see people walking through hallways with their computers. Like, kudos to you. You're doing things and doing things. But if you can safely add in the chat, I would love to hear some thoughts, questions. What are you doing? What's working right now for you? What hills or mountains even have you overcome as a district? And then also thinking about, where do you need help? So I'm going to just go into the chat here, and we have a question. Legally, would an SLP need to have additional malpractice insurance due to safety with diets and feeding? Dawn, am I allowed to answer these legal types of questions? I want to make sure.
Sorry, couldn't get to my unmute button there.
That's okay.
Yeah, I think you can go ahead. I could say, just from personal experience for that one, it's not a requirement that you hold your own insurance. Your school district has a legal team. Many are still members of their union at their district, and that should help cover you legally. Personally, I always have held a separate insurance policy that ASHA offers. And part of that is because I used to provide some practice outside of the schools as well in skilled nursing facilities. So I wanted to always make sure I was covered in case I wasn't backed on, some decision that I made. But Jennifer, do you have a
No,
different
I was going to say exactly all of that. So
Okay.
good. This is a great question here. I don't know if it's Casey or Cassie. I apologize if I'm saying it wrong. Some of our kids do take significant amounts of time to feed, and lunchtimes go so quickly. How do we approach this, right? Because this is a really slippery slope. So we want them to participate in mealtime. They have to participate in mealtime for growth and nutrition. But then we're looking at, are we losing recess? Are we losing math time? Are they not getting their one-on-one for reading? And so I don't want to answer that question specifically, but to say, I think the answer to that is, if the child needs that amount of time to eat, to get their nutrition, they need that amount of time to eat, but how do we accommodate that? And that's not a decision that I or Dawn or anybody here can tell you. That's a team decision. And that's where we look at, what can the team do to support this child in their environment while making sure that they can have the time they need to eat while still meeting their daily requirements, their yearly requirements for making sure that they're getting their educational hours in. Dawn, would you answer that any differently?
No, I think you covered that very well, Jen.
Thank you. I'm not sweating. No. Okay. Couldn't somebody ask me something about like dysphagia? No. When OT, SLP, and PT are not in the classroom every day, do they still have supervisory duties to the personnel who would be administering intervention techniques? That's a great question, Jessica. So again, it's about competency and what we call role release. So the individual being able to train somebody where they are competent, and it is now within their scope of practice, within their skill set, that they have been trained to provide that to the best of their ability. So I would say to that question, if you are doing things within your best ability to support somebody in learning a skill, and providing information to a person that is within the best interest of that student's safety, I don't think that you personally are responsible for that individual who's carrying that over. Dawn, would you answer that any differently?
I think Louise wants to jump in.
Yeah,
Okay,
I just want to jump in from a nursing standpoint, because I've never heard the term that you just used, Jennifer. So in the nursing world, there's a legal term, role release. We don't have such a thing in the nursing thing. It's delegation, which is a defined legal thing. And so what that means is that someone else, it's not within their scope of practice. So a UAP, a teacher, is not within their scope of practice to do a tube feeding, but you train them, you delegate it to them. You, as the registered nurse, retain responsibility, and part of that whole delegation procedure is to evaluate and supervise. So it's different for nursing. So I just wanted to point that out, so that if there's any school nurses listening to that, they're not confused and think, I've heard different. So thanks.
Right. Thank you for that, Louise. And I think that question could get a little murky too, right? Like a lot of these questions aren't very black and white. Anything else you wanted to say to that, Dawn, before I go to the next number here, or the next question here?
I think you can move on.
Okay. Courtney, thank you for sharing. You were surprised to find out how much you enjoyed working with a student regarding feeding and swallowing. It is very rewarding, right? There's so many parts of our jobs that are rewarding. And I love that you shared that from a standpoint of, I know Courtney, and Courtney's favorite thing to do is not feeding and swallowing.
No, it's not my bag. I thought
It's
it was
not
just
your
to add a
bag.
comment, so I did. There you go. But I really enjoyed it.
Yeah, that's great. That's great. And so she went outside of her comfort zone. She got herself updated on what she needed to do. She learned it. She found that she enjoyed it. Caroline, for our students with motor impairments who aren't on a special diet, how do we judge or advise foods that may be unsafe? For example, a student choking on an apple slice during a group therapy activity. So that's a whole nother presentation that we're going to be talking about when we talk about assessment. So I'm going to put like my professor hat on and say, hold that thought, because we're going to talk about that and what do we do for those individuals? Because we are not here as school personnel to make a black and white determination of what a diet should be or how much a child should be eating. That's not our job. We are responsible for carryover, for implementation, but we are also responsible for referral, right? And if we need to refer outside of our scope of practice, that is where we need to be. So Caroline said, great, thank you. You're welcome. Okay. Aubrey, I love the name Aubrey. Would SLPs in the school work on and manage feeding abilities, or is it more carrying over what medical SLPs recommend? I'm so glad you asked that. I'm going to say that ad nauseum for the next, are we 6 more months, 7 more months? In that, yes, we are responsible. You are responsible for carrying over medical SLPs recommendations. You can ask me that question as many times as you want, Aubrey, because I'm glad that you're hearing it. That's great. Meredith says, what if parents do not want PFD worked on in school? Do we need to document this in the IEP? And then Jen said she has a similar situation. The child has had swallow studies completed. Parents don't want to share medical recommendations with us. They want to feed the child regular school lunch items when we know it's not safe. Again, those are team decisions that have to go through your administration, right? Because you are still responsible for safety. And I'm going to defer those questions again to your administrators to say, okay, do we feel that there is a risk for this child? And what are our next steps? And those are really some difficult conversations. And so I applaud you for asking those questions and being willing to say we need to have these conversations. Laura, said yes. She said that this is a great question. School districts are seeing this where the parents are saying, no, they're fine. And I think what I would like to say to some of these questions is, so much of what we do with the kids is relationship based with the kids. And myself as a practitioner that spends a ton of time with the families, and you guys do a ton of time with the families too, but you're with the kids most of the time. It makes me pause and go, gosh, that relationship with the caregiver, are they feeling like they're being heard? Are they feeling like they are participating? Are they feeling like we're respecting them as the parent of the child? And do we need to work on that relationship too? That's a big piece of this in feeding, is working on the relationship with the caregivers, which I know you all do a great job of, especially when you have classrooms that have so many large numbers of kids. So that might be a relationship that might need a little bit of extra time. Okay. What if the student is not under the treatment of a medical-based SLP? Yeah, we have to talk about that referral source and getting the family to understand the importance of that, right? And we'll talk about that when we talk about assessment. How do we address a parent that only wants their autistic child to only eat Reese's peanut butter cups, Goldfish crackers, cheese slices, Sour Patch Kids, and juice? That sounds like my college diet, with their hands versus participating in a mealtime routine, including positive food exploration and tool use program. So this is a really great question, Cynthia, in that, do we know why this parent wants them only to do those preferred foods? Does this child have significant sensory experiences with other foods that have been so negative that maybe the parent is preventing the child from having further negative experiences? I mean, I've seen kids where if you put a piece of a vegetable in front of them on their plate, they will literally have a vomit, emesis. So they may be protecting their child from some negative experiences. It may also be that you are thinking in your therapeutic mind, we want them to do some positive food exploration and tool use, and that is awesome. I want to guess that maybe you're an OT. And yeah, so again, having a conversation with the parent of, I'm not going to force them to eat anything. I'm not going to force them to touch anything, but here's the therapeutic value of what I want to do with them. That's another one where I think you have to go back to the caregiver and really make sure they understand.
I'm going to jump in there for a
Yes.
second and just also connect it to the IEP as well, if you can. And that's a really great opportunity to have those conversations with the parents and the staff at the same time, just sort of exploring what is their resistance to it. And this is just what it would look like. And then if you can connect the disability related needs to the IEP goals, those kinds of things can really support you in providing those kinds of interventions too, if it's documented that way.
Mm-hmm. What if the student is not regularly seen by a doctor or medical information is old or non-existent? Again, that is a conversation with your administration that needs to be determined. And I say that gently because we do have instances where there are children who should be under medical care and are not. And that again is a very, very delicate situation that needs to be approached through a team, and making sure that we are keeping the safety of the child in mind overall.
Jen, I want to just give one quick shout out to Luis and school nurses. I had a situation like that where the child was not receiving medical care, and I had some pretty significant concerns after conducting an evaluation. And I worked with the school nurse who did an amazing job getting that kid to a doctor, working with the family. And it was really important because they did find something very serious that needed to be identified. And so shout out to the school nurses, and they can probably help you in that instance, I would think.
Yes,
Yeah.
thank you, Courtney. I was going to I'll echo your words, and I was going to say the same thing. I have worked with school nurses who have been great connecting students and their families to medical services that they needed.
I love that. I love that. Thank you. Yes. All right. So let's go ahead to our last slide, ending right on time. I want to thank you. I think, again, some of you have alluded to our next topic, which is utilizing a team approach. We want to see you next month. Show up, bring a friend, and then have your friend bring a friend, right? Or watch the recordings. We know you are all very busy people. And we really appreciate you participating in this. So if you have any questions, you can let us know. Dawn's going to give you a little bit of spiel here about how to get all the handouts and all those fun things that you need.
Thank you, Jen. This has been great. I have had Michelle has been putting in the chat throughout the session a link for you that you can use throughout the year to get any recordings that you want to rewatch, or if you missed a month, your handouts will all be in that. And also there's a certificate of attendance or participation that you can use for professional development hours that you track on your own. And this would cover ethics if that's something that you're needing hours in for at least 1 hour of it. So the certificate of attendance has each of the dates of this year-long series. And as part of your code of ethics, know that you are only supposed to claim time for anything that you've watched in full. So if you watched the full hour or attended or watched the series afterwards, you can claim the time for that session. So thank you so much for joining us today, and we look forward to seeing you on November 6th.